who is teaching us about field osteosynthesis in orthopedics. So over to you, sir.
Thank you, Janki, and good evening, everybody, and welcome to this webinar brought to you by the Orthopaedic Research and Education Foundation. Today, I'm going to talk to you about failed osteosynthesis and look at some of the reasons why they failed, and part of it, I hope, will be interactive, but we'll start with some basic facts about what happens. Okay, so what is clear is that with the AO, it has revolutionized the treatment of fractures, and their basic philosophy of life is movement and movement is life, and early functional rehabilitation of trauma patients. We have been able to get multiple patients with severe injuries, multiple fractures, back to their functional state within a short period of time. However, while there's no doubt that outcomes have improved significantly, there are numerous potential complications. Things do go wrong, and they often require multiple secondary procedures, and sometimes the results can be worse than that with conservative treatment. In fact, these problems significantly increase the morbidity. There are significant financial as well as psychological and social implications. And McKeish, Metish, and Yu in their paper 1998, and there have been subsequently many other papers which have looked at the disability and the negative impact on quality of life, and they find that it is greater than a patient on renal dialysis or ischemic heart disease. So if you have multiple non-unions, especially infected non-unions, the results are actually, in terms of negative impact on quality of life, greater than that with patients with renal dialysis or ischemic heart disease. Now, if we look at fracture treatment, there are three important variables. One is the patient himself, the second is the fracture itself, and the third is the surgeon. And you have this triangle of variability between the patient, the fracture personality, and the surgeon. And we have to really look at various factors. But there could be patient factors such as the general health, osteoporosis, metabolic diseases, smoking, alcoholism, and compliance. So a patient like this, who's already got fibrous dysplasia and a significantly bored bones, a simple fracture of the femur can become complicated because you need to do multiple osteotomies to get the femur straight and then nail it before you can get a satisfactory outcome. Similarly, fracture factors can matter. The fracture, depending on their site, the geometry, the comminution, the vascularity, the soft tissue injury, and whether it's an open or closed injury, it makes a big difference in terms of the outcomes. So if you have a patient with an injury like that, in spite of the best treatment, he may not have a very good outcome. And similarly, something like this with a sort of blown out injury of the knee with the proximal tibia missing, the best you can do is an Ilizarov reconstruction and get it down to a fusion, which is otherwise not an excellent result, but in this case, it may be the best result possible. And there are surgeon factors, and there are multiple factors involved here, including the expertise, the infrastructure, the choice of implant, the technique of fixation, and of course, the soft tissue handling. So here, if you have an X-ray like this, you know that something has gone wrong with the way the surgeon has planned this operation. I mean, it's surprising how he can miss the head altogether in a DHS. Obviously, this is something which we won't expect to see on a regular basis. But you can have less obvious problems, such as this, where you can see that because of the angle of the two implants, it doesn't allow the controlled collapse that a DHS is supposed to have for its healing. And then you go on to have a failure and a problem with the healing. So in this triangle of variables, the surgeon probably plays the most important role, and a simple fracture managed poorly can have disastrous consequences. For example, this infected non-union in a very simple fracture of the tibia ends up needing an Ilizarov reconstruction to get it back to heal. Or something like this, where a proximal tibial fracture has been fixed with a plate, it gets infected, there's a sort of soft tissue injury, there's a blowout of the wound, and you end up having to do an Ilizarov reconstruction and end up in a fusion of the knee where it could have been a relatively simple fixation, or even if you had treated it conservatively, you would have had a better result. On the other side, it's possible to get good results in seemingly difficult situations if the treatment is optimal. Okay, so you can have patients who have multiple fractures such as this, including comminuted fractures, segmental fractures, etc. And with proper treatment, you can get all these fractures healing and back to a normal sort of life where the patient can get back to his normal duties, etc., within a short frame of time. So your good results really come from experience. Unfortunately, experience comes from bad results, and it's wise to learn from one's mistakes, but it's even wiser to learn from others' mistakes. So if you can learn from mistakes that others have made, it's better for you in terms of your results. So this was based actually interestingly on a presentation by Rajshekharan in the 2002 COE meeting. And following that, we actually looked at the number of patients we had who had failed osteosynthesis and underwent treatment in our center. It included ununited fractures with implant failures or non-unions with or without implant failure, where subsequent surgery has been required. So when we looked at this, we had a number of patients, altogether 756 patients. Some of them had treatment elsewhere, most of them had treatment elsewhere, but some of them had treatment at our center as well. And you looked at them, and then if we try to divide them into patient-related factors, fracture-related factors, or surgeon-related factors, you can see a majority, 63% was surgeon-related factors. And if you included infection as part of surgeon-related factors, then it was 80%. So almost 80% of patients who do badly because there's been something not perfect. I mean, it may not be grossly wrong in every case, but if you go back and see the original X-rays and the original fixation X-rays, you can make out that it is not perfect in every sense of the word. So a patient who has failed fixation is not really a long-term patient. It's just a short-term patient that you haven't been able to treat successfully. Okay, so I mean, I'm not saying that you can't go wrong. Everyone makes mistakes, but I think you have to try and reduce the number of failed fixations that you have in your own practice. So I'll just go through some examples, some of it which I'm going to put out to you as questions. So this is a Monteggia fracture in an adult, okay? And this was treated with this plate. Now, would anyone want to comment on this fixation? Can we have?
Yes, sir. So, Prashanjit?
You can switch on your videos and your audio.
Yeah.
And just tell us what you think is right or wrong
Yes.
with this fixation.
Yes, Rajan. There.
Plate should be longer.
Yeah.
So is the reduction adequate?
Yes, sir, but plate should be longer, at least 6 cortex.
Okay, anything else? So how many cortices does this hold?
Distally, sir,
6 cortex and proximal, distally 5 cortex actually, or proximally 4 cortex.
So does it hold 4 proximally? Because if you look very closely at the fracture, it goes really onto this part, okay? So you really have one proper screw on the proximal fragments, and it's not a surprise that this fails. And you can now see how this screw was actually going into the fracture site, okay?
Class 7.
Okay, so can we have the external noise off? Okay.
Yes, sir.
So this is how it fails, and now to get this to heal properly, you need to fix it stably. You need to put adequate length, and in this case, we also added bone graft. Now you can see that it's got multiples, a bigger plate, more stable fixation, and this then goes on to heal satisfactorily. Okay, here's another case. Anyone who presented 3 months with failed fixation? So anyone has any comments on this?
So it's
The reduction was not adequate and the screw is outside the head.
So one screw is outside the head, the other screw is outside the nail. Okay.
Yes.
So if you look at this, even though if it's probably a relatively undisplaced fracture, we don't have the original X-ray, but the nail has been done in such a way that it has caused a failure, and you can treat this by any method. You can treat it with another nail, but we treated it with a DHS, which allowed it to go on to heal satisfactorily. So all you have to do is to put your implant properly, get a good reduction, get your valgus corrected. It should not be in varus. So any proximal femur fracture, remember, varus is the biggest enemy that you can have. Here's another one. So comments on this?
I think someone else, if
The reduction is not
uh,
adequate. The THS richer screw is outside the head.
And why?
The angle may be different of the neck shaft angle of the DHS and the original one.
What else? So if you look very carefully, you can actually see where the original DHS was. Okay, it was only till here. Okay,
Yes, sir.
so what is the TAD you want?
what is a normal TAD which is acceptable in DHS?
5.
okay.
You know
Sorry?
what is TAD?
Yes, sir. It
But
affects distance in both vertical and the horizontal.
So how do you calculate that?
In both AP and lateral view, from the
Yeah,
distance between the tip of the richer screw to the joint space, tip
is
of the.
is that
So
the
it should be less
correct?
than. It should be less than 25 millimeter.
But is
In
that the correct definition? The joint space? Because here, if you see it, it's outside the joint space.
yes, sir.
So it should be at the center of the joint space. Okay. So
Yes,
you
sir.
can, so even if you are close to the articular cartilage, but it is here, your distance is from there to there. Okay. You understand? Can you see the arrow on this?
Yes, sir.
Yes, sir.
Okay. So it has to be to the center of the head joint space. Okay. So your distance should be within 10 millimeters, both on the AP and lateral. Maximum total distance may be 20 to 25 millimeters. Otherwise, the chances of cutout are very high. And who did this study? So this is a well-known study by Michael Baumgartner, where they did a pre-study where they looked at the distance and the failures, and then they corrected that. And in the subsequent cases, they kept the distance at 20 millimeters, and they had almost no failures in that series. Okay, so they went on to prove the hypothesis by doing a subsequent study to look at that. Okay, so this is what we did. So here you can see now the tip apex distance is correct. The valgus angle is correct because we did an osteotomy, and you can see how this has gone on to heal with a good result and good function as well. Okay, now what about this? This is an infected non-union. Okay. You can see the silogram now. Infection can happen to anybody. It's not something which is in itself a reason to blame the surgeon. Infection, unfortunately, is still not possible to get 0% infection in trauma cases. But when you do get infection, you must act, and you must not let it sort of linger or fester and then end up with major problems, like obviously was done in this case. This patient came to us almost 8 months after this. And there you end up having to do transport and Ilizarov reconstruction and do a bone transport and a complicated procedure, 12 months post-op and 13 months after the fixator removal. Now you can safely say that the fracture is healed and the infection is controlled. So extensive surgery for something which could have been managed fairly well, even with non-operative treatment. Now, with the advent of lock plates, we've had some other complications which were not there earlier. Okay, so what is this? Anyone?
Trophic non-union.
What non-union?
Hypertrophic non-union.
Why do you call it hypertrophic? And what?
So this is atrophic type of non-union.
So you have two opposing views here. So it's,
Yes, sir.
it's neither hypertrophic nor atrophic. What is the problem here? Problem
Sir,
here.
anatomical reduction, that reduction is not focused.
Compression was not done.
No, so if you look at all the screws, they're all locking screws, okay? So
Yes, sir.
yeah, and you have a gap. Okay, now if you have a rigid fixation and a gap, all the stress distribution comes into that gap, that small gap. Okay, so there's a high strain environment which will not allow the fracture to heal. Okay, so what about this?
Cooper reduction is not this.
Inadequate, sir.
Yeah, but what is the problem here? So what happens with these lock screws is that you don't get the biofeedback that you do with normal screws, okay? So in a normal screw, if you were using conventional screws, when you're tightening it, you will feel the tightening in the head, okay? If with the lock screws, you could be in air and the screw will tighten to the plate and you won't realize it. And in this case, all the screws have really missed the head, okay? But the surgeon doesn't realize it and then ends up with a problem like that. What about this? So this is again a situation of high stress concentration in a periprosthetic fracture, where you filled all the screws and you've got this small gap where the fracture is, where all the strain is, and you end up. What about this? So this is the other extent, that it's an unstable fixation. Okay, so although you've got a long plate, you probably needed more screws or the gap was too much, so it's kind of self-dynamized. And here you have problems with implant removal, which you can see fairly regularly with these lock screws, especially the 3.5 millimeter lock screws. They very often have, there's a lot of problem getting them out. They can, it was originally called welding, cold welding, but it could be cross-threading. And the reason that these screws don't come out is because the titanium heads get really forged onto one another and it becomes very difficult to remove. Okay, so these are problems which we see from day to day.
Right.
Sorry?
Sir, in previous X-ray, in hemiarthroplasty with the long plates, is the unicortical screw is the reason for the stress riser?
So these, so if you looked at the original list plate, okay, most of those were unicortical screws. Okay, these are screws with there's a self-drilling, self-tapping screws. Okay, this is an X-ray which is not one of our cases, but from a presentation from someone else. I can't quite remember, or was it from the net or something? Or it's probably an AO case that they showed, where you can see that all the screws, but the main reason is all the stress concentration is here because there are lock screws in every hole, and then the plate has too much stress concentration at one level where it can break. Okay.
Okay.
So, so what you find is that surgeon-related causes are most frequent. This leads to misery for the patients and is disappointing for the surgeon as well. And interestingly, very often you need multiple procedures. So here's a patient who has a plating done, that fails. He has a subsequent plating done, bone grafting, that fails. And then you end up having to do a nail in this particular case for it to heal. Here's another patient. I think this one, we've probably repeated this. This is a revision fixation. I think I showed it in the humerus non-union or interesting cases talk where we had initial fixation that failed. We had a revision fixation with bone grafting that got infected. We had debridement with antibiotic spacer. Now, each of these is by a different surgeon. So the implant was retained. Then he went to another surgeon who put in this nail. Luckily, the infection was controlled by them and bone grafted it. But this didn't heal. And then he finally came to us in this situation where the shoulder is gone, the elbow is gone, and there is this frank non-union, atrophic type of non-union. Here we have to really freshen the bone ends. You have to get good stability. So we had to use 2 plates here. This was him 4-5 months post-op. Getting back some movement, the shoulder is still stiff, but gradually getting back movement. And luckily, the fracture has gone on to heal well. So here's another patient. This is a 24-year-old gentleman with a clavicle fracture. Now, this was what was done. Now, what do you want to, what's your comment on this one?
This plate is
Longer plates.
longer plate should be used, and
So why longer plate? It's a simple fracture. It's actually a
conservative can also be done in this case, sir.
no. So this is,
It's
if you look at the ends,
non-
it's sclerotic. So it's already a non-union. Okay, so in a non-union, you can't use flimsy plates like this. Okay, you understand? So this plate is too flimsy. Okay, it's a recon type of plate which does not have the kind of hold that or the strength that these non-unions require, and this goes on to fail. And then this patient comes to us 6 years down the line. Okay, now what do you do?
Removal of the plate and bone graft with the longer plate fixation.
Yeah, but do you have enough
So
length to get a good stable fixation?
difficult
So what you have to do here is you use 2 plates, use one anteriorly, and then the superior one is the lateral clavicular plate. Okay, so that's how we did it. We used the LCP on the anterior side and this superior clavicle plate. These are different views. These are the caudad and the capillate views. Which just like the acetabulum for the clavicle, you need 3 views at 45 degrees to the horizontal. So you have a true AP and a 45-degree caudad and a 45-degree capillate view to get all 3 views of the bone. And this then goes on to heal well with good function. You can see that the bone has healed. Okay, so you can see through here that the bone has healed well and it's in good function. So now if you want, you can take out the plate if he wants it. What about this 28-year-old lady, 5 months since injury? So are you happy with this fixation?
No, sir.
So what will you do?
Sir, additional circlage.
Yes. Circulage with the SSY.
Flush with SSY. So you just with the nail still there. You think it's going to work?
Sir, additional and then sir, plating, sir.
Yeah, so this was not easy because what happens is there's a lot of fibrous tissue there. Okay, so the first thing is you have to rule out infection in these cases. Okay, and always have blood for these. So you can see how much fibrous tissue there is. And it was very difficult, even though that is the gap. It's quite a large gap. To get this to close, we had to really go step by step, release the tissue, get it clamped, and then put the circlage. So it wasn't that you can just put a circlage and clamp it. Okay, so you have to gradually get it reduced, then put the circlage, add a second circlage, and then put this plate, which is a locking plate. Okay, we could also get one lag screw here, so then we could take out that circlage after that. Okay, so that's him. That's her. She's gone on to heal and with a good function as well. Okay. So the key factors when you're dealing with these are, one is the implant removal, pressuring on bone bends, You have to get good contact of good live bone. You need to compress these. So here it's a combination of a lag screw and the cerclage. And you must avoid varus, okay? Like I mentioned, all these proximal tibial, proximal femur fractures. In fact, most fractures don't like varus, okay? Whether it's proximal humerus, proximal femur, distal femur, everything. If you have varus, the chances of failure are much higher. So here's another one. This is nailed, okay? Looks reasonable, but is this stable? Inadequate, okay? So that's what happens. And this, what is this sign called?
Z.
Z
Great,
sign, sir.
great effect, sir.
So why does that happen?
Sir, on the vertical plane, both the both the bolt should be at the same level, but in primary fixation might not be in the same level due to the weight bearing, the stress. These effects happens.
So do you think they should be at the same level? Because there are different theories about it. And the basic reason for this happening, either the Z effect or the reverse Z effect, is instability, okay? Because there's instability, there's movement, and eventually the screws back out. One backs out more or less, one goes the other way, and you get this kind of Z effect or a reverse Z effect. And here again, you have to get good stability, get lag screws across, and then get a good fixation, and this will then go on to heal. Okay, what about this femur? Simple nailing. Are you happy with this?
Yeah.
So the screw is okay. So don't worry about the proximal screw. That's okay. Yeah? I think distally what happens is the nail is not long
Short.
enough. Okay. Secondly, the fracture is comminuted. And in that area, the medial side is inadequate. You have a nail which is, the diameter is not as thick as it should be. So the problem is that you have a inherent instability, and this over time. So this is what happens over time. And 1 year, 1.5 years down the line, this is what you get. Now what is happening? Anyone? So the fracture is going into
Yes, sir.
varus. There's bone trying to heal, but because it's unstable, it doesn't heal.
Mechanics.
So that is a classical hypertrophic non-union. Okay. And this then goes on, the nail breaks and finally presents to us. And then what do you need to do?
Stability.
Pardon?
Removal of the nail, and
Yeah.
then the
Nailing, plating
Cleros
is
parts should be osteotomy, and then longer plates,
What
locking plate.
Why do you need an osteotomy here?
The hypertrophic scleros part should be excised,
So
otherwise.
you should be excised. Who told you that? So
Sir,
what's
both the end of the fracture side where the hypertrophic non-union occurs, the canal will be clerosed in this case.
so why do you get a hypertrophic non-union? And what is the problem in a hypertrophic non-union?
So biology is good, but there is an deficient reduction.
Inadequate stability, okay?
Inadequate
It's unstable. So if you looked at the original reduction, that was not bad. But because it was unstable, it kept gradually the stress, the bone is forming, but it can't heal because of instability. So what you need to do is provide good stability. And how do you
Yes.
provide good stability?
By stable fixation.
So you have to
with the-
get stable fixation. Either you can use a lag screw and a plate, or a plate and a nail, okay? So here
Yes.
what we've done is so you know what this wave plate does?
No, sir.
So how does a wave plate work? So basically what it does is, so when you have an fixation which is on the femur, what happens on one side?
It transfers the weights.
Yeah, but what does you're right in the sense that it does transfer the weight-bearing axis of the fixation, but it lateralizes it so that it is more in the center of the bone. Okay, so you don't get this varus stress on this level. Okay, and you can see now how without any bone graft, okay, this has gone on to heal, and now gradually with time, all this hypertrophic bone will reduce. Okay, this is still early, where you still have hypertrophic bone, but once it's healed, it will tend to gradually reduce with time. Okay, now here's another one which has failed multiple times. Okay, so it's got 1, 2, 3, 4 surgeries before it's failed. And so what do you do here? So this is where you need more stable fixation. Okay, so you can either combine 2 plates or a nail and plate. Okay, so here, this is what he came to us with, and we did. So that was removing all the screws, the bone ends, and what we did was we put a lateral plate and also an anterior plate. Okay, so that you get a good stability, and now you can see how this goes on to heal. So you reduce the stress on one plate by putting the second plate. Usually the second plate only has locking screws. You can see this anterior plate only has locking screws so that you're not damaging the circulation anymore. Okay.
Sir, what
This,
was the reason of this failure, the previous one?
you tell me.
Inadequate stability.
First nail, inadequate stability. Okay. Then plate, too much stability. Huh?
Mm.
With stress
So many screws.
concentration. The same thing again. Okay. So small gap, too much screws, all the stress gets concentrated in that small gap. Okay.
Okay, sir.
So this is the same case which I've kind of duplicated. Okay, now what about this? I saw one with the head pulling out, here the shaft is pulled out. So what do you do here? And what does this mean?
It's a varus collapse.
Yeah, but why is the shaft? It's usually the
First,
screw pulls
fix.
out, the lag screw pulls out or comes out. No? It's even if it's a varus collapse, it tends to go that way. But here the shaft is pulled out. So osteoporosis can go both ways. And here, because it's in the lower part, this is holding well because the tip apex distance is good. Okay. So look at that. It's gone all the way there. The tip apex distance is good, but this side, because she's a 74-year-old lady, osteoporosis, this ends up going on. So what do? Again, similar thing. You get the screw because the hold was good. You use the same position. You did a valgus osteotomy and a fixation with a DHS plate. And again, you can see how this has gone on to heal. This X-ray was sent by this patient is in Ranchi or somewhere. They sent the X-rays over, and you can see she's gone on to heal well. Similarly, another one where you can see the plate has broken with a varus collapse. So you can have varus collapse with pull out of the lag screw. You can have varus collapse with pull out of the shaft, and you can have varus collapse with breakage of the implant. Okay, various things. Okay, so here what do? You do again valgus osteotomy and fixation. Okay, so that's so here you can see there's opening on the medial side. Are you worried about this?
No, sir.
Not at all. Okay, shouldn't worry about that at all. If you got good contact here and you got this valgus, because you've got you can see how this has gone on nicely to heal without a problem. Okay. But there are times when you have no choice but to do an arthroplasty. Okay, so if you have something like this which fails so badly, you have no choice. If the joint is okay, you can do a hemi-arthroplasty. You need to wire the trochanter properly. Here's another case which has failed very quickly. Now, if you look at this, are you going to try to salvage this hip? Probably not, because if you see this fracture, it's actually extending onto the neck, okay, onto the head. Okay, and here you can see this fracture is actually going on to the head. because we do it in the supine position, it's easy to judge the anteversion, etc. So we do that, and eventually we did a hemi. And here the trochanter had healed, so we didn't do wiring, but otherwise use a long stem and use wiring out there. So I think basically one has to achieve a satisfactory biological and mechanical environment for satisfactory fracture healing. Failures are not implant specific, okay? The principles are much more important. And a mind that understands the principles will devise its own methods. Okay, so it's not that the plate is good or the nail is good or one is better than the other. It's how you apply it that is more important. So get it right first time. There was I think it is Reginald Watson Jones who said that bone is not filled with red marrow, but with black ingratitude. I think we should prove this wrong by doing things right the first time, and then you will not have the problems that you have all the time. Okay, thank you very much. I'll stop there and take any questions that they may be. Yeah. So,
Yes, if anyone have some question, then please ask.
otherwise, otherwise, I'm going to assume that you're all experts at fracture fixation. Okay.
Yeah. Sir, in you have shown one case in which that the shaft part of DHS was come out. So in that case, sir, you have kept the same DHS screw or you have changed that leg screw also?
So did you see the X-ray?
Sir, because I have not remembered it, when I see the next one that
So if
I
you
have
see
not.
the X-ray, you will know that I can't leave that. Huh? So
Okay.
let me see.
In case of failure with the intermedullary nail, when you use the removal of the nail and the plate, so it should be always in the locking plate or either a compression plate also.
You must compress, whether you use a locking plate or not. Any non-union needs compression. So if you saw that, if you saw it very carefully, you'd see the hole for the compression. So here's the patient. So now you tell me what you would do. Can you use this because this is sticking out so much, yeah? Because of the
Yes, sir.
collapse. So you have to change it. But this same track had a really good hold. So we didn't need to change the track, okay? But if this track was not holding well, we'd have to change it or add cement or something like that. Okay.
Okay.
So if you see this, where's that? I'll show you that. So most of these, when we use compression, you'll see an additional hole. If you look at it carefully. So here, if you look at that, can you see this hole here?
Yes, sir.
Okay, so that's where the compression device has been used to compress it. Okay.
So what should be the adequate length of this plate? How can we decide on this case?
So how do you decide? Tell me.
Yeah, it's the same question Risu has also asked. How much length of plate to be used for fracture?
The three times there's a fracture defense.
So
Cortis
this
is
is for the primary one, 3 times of the fracture segment. But
So
in
what are you looking for in a non-union?
sir biology deficient or sir stability or sir.
Yeah, but any kind of non-union that you're dealing with, your fixation has to be close to absolute stability.
Absolute.
So your principles of fixation would depend on absolute stability, not on a bridging fixation. Okay. So you don't have to use very long plates. You need to have enough screws on either side of the fracture, and the length would vary with the level of osteoporosis. Okay. So if it's an osteoporotic bone, you'd put more screws. But if it is a regular good quality bone, then you would use the same number of screws. So like in a humerus, ideally 4 screws on each side, because the humerus also has a rotational stress, which is much more. In a forearm, it's probably be 3 screws on each side. Ulnar tends to be a bit longer than the radius. So I think you vary like that. Femur or tibia, 4 screws on each side. Okay. But Today we combine it with lock screws, which give you a much better pull-out strength. But what is important is to get absolute stability, which means good contact, good alignment, and compression across the fracture. Okay, whether use lag screws or use the compression device to get transverse compression on the fracture. Okay, so you can see that we use the compression device, or there are some other ways you can do compression using a screw and a sort of Verbrugger's clamp, etc. Okay, but ideally you should compress the fracture site. Sometimes it's difficult because of the length and soft tissue, etc. But wherever possible, try to use the compression device rather than just relying on the compression holes for compression. Okay.
So one
So this would be
thing
the
about
low contact type of plate, or sir, because the nail already the endosteal supply has been gone. So if we plating after that case, so periosteal is also disturbed.
So the endosteal supply doesn't remain gone forever. Huh? It comes back very soon after nailing.
Okay.
Okay.
Sir. Okay.
yeah, that is also a question how many days it require for that after the reaming that endosteal supply will come back. They usually ask in the exam. And
So,
sir, about
yeah.
just one thing, sir, about the working length, sir. During the Viva, they used to ask in terms of nailing as well as plating. For nail, it is easier. For plate,
So what do you call the working length in a nail?
your working length means that between the screw of from the fracture, the nearest screw on both sides, that length we can consider as working length,
So what do you want, a short working length or a long working length?
a long working length.
Is it?
Because in nail, no, sir.
The
Why do you
inverse
want a,
Yeah,
short
why,
long.
why do you want a long working length? Tell me that.
So short working length.
Yeah, because you want
It was
contact.
it
Okay,
was
so it's
contact is
area of bony contact on both sides and the distance between the two. So it could be the screw, it could be the isthmus. Okay, so that's where
yes.
you look at it. Now in a plate it varies. Okay, so even in a nail and this thing, this working like concept varies depending on who you talk to. Okay, so one could be the, so if you're doing a bridging plate, it is the distance between the two screws that you've got and the length of the plate. Okay. In a compression mode, it's different again. Huh? So I think the working length concept is a good concept, but there's a lot of confusion about what you mean when you say working length.
Yes, so because like when there are so many screw, then it is quite difficult to understand. I think the nearest from
So
the
for
fracture
the
that
bridging fractures, that is okay. For a
yeah.
for a compression plating, it is really the length of the plate that really works as the.
Sir, one more question. In case of nail, reaming with the larger nail is better, or the unreaming the one size lower nail is better option?
So what do you think?
So that is the dilemma, because some says the reaming should not be done, some says reaming should be done.
So I think now this is fairly well established. If you use unreamed nails, which had become popular for open fractures, especially the UTN and the UFN, where you put in nails without reaming it. The problem was that you had a higher incidence of screw breakages and non-unions and delayed unions. Okay, because of the size of the nail was not enough. So you ended up with unstable fixations. So nowadays, by and large, you would ream it to a size which is appropriate for that particular bone. You don't want to over ream to get heat necrosis, but you want to ream it adequately to get a good size nail in. Okay.
Thank you, sir.
Sure. Okay, I think we can call it a day.
Yes, sir. Thank you very much,
The
sir.
next step. Okay, thanks very
Yeah.
much. Okay, bye.
Yes, sir. Next, yes.
Okay, bye.
Anything,
everyone.
Raju?
Thank you, Golan, sir. Thank you, sir.
Okay.
Okay, bye.
It was
everyone.
a very interesting, nice lecture, sir. Thank you,
Yes,
sir.
sir. Very nice class. Yes, sir.